I'm David Roye, and I have a role as the Executive Director of the Weinberg Cerebral Palsy Center at Columbia University. My long-standing interest in the assessment and treatment of patients with CP. And I want a little call out to Hiroko Matsumoto, who's our epidemiologist and heads our research division at Columbia. So these are my disclosures, none of which have any bearing on what we're talking about today. So we've had a wonderful few minutes looking at the reason for needing to have a holistic assessment around our children when they're having pain, or to assess them holistically, really no matter what domain we're looking at. And it's important to consider, as Veronica just told us, the impact of pain on quality of life, function, and daily activities, not just the symptoms. And we want to, whenever possible, to engage people that we're looking at or assessing to self-report. We would really like to have your child or your young adult, we deal with the lifespan at the Weinberg Center, report their quality of life issues themselves. Adult patients with CP face more chronic pain than children, with more than 2/3 reporting chronic pain. So pain is inadequately evaluated and treated in our patients with CP. And interestingly, Hirsch found that treatments that patients rated as most effective were the treatments that were rarely used or provided. So there's an imbalance between the beneficial treatments and the most commonly used treatments. So measuring only pain perception symptoms is really too simplistic. It's not that it isn't necessary in sometimes. I mean, I am unfortunately fairly sure that many of you sitting here have been in the hospital with your child and have had to rate your child's pain on these visual analogs. But that's really only, and for that purpose it may be valid, but for an overall assessment, for a holistic assessment of how that pain is impacting on life, it's not enough. So this is another way of looking. We just saw the presentation of the ICF, and this is another way, if you will, of looking at these issues. Psychosocial distress and symptoms both impact on health-related quality of life. And health-related quality of life is not just a symptom, it's not a disease. You need to consider physical functioning, but you also want to look at social functioning and emotional functioning. And even the symptoms need a more holistic assessment. We need to look at the frequency, the severity, not just the presence or absence of the symptom. So another concept that is one of my own, if you will, prejudices is the issue of dynamic versus static measures. So most of us are most accustomed to a static measure. You have a questionnaire either on a computer screen or in pencil and paper, and you answer the questions, and you go from question 1 to 2 to 3 to 4. And it's necessary for me as a clinician or as a researcher, I want you to answer all those questions. I don't want any blanks left. But it is what it is. Dynamic questionnaires work differently. Behind each question you answer is an algorithm and many other questions. So as you answer that question, it brings up others. So the static questionnaire, it doesn't change based on your responses, and the questions are in the same sequence regardless of the answer. And all the questions are posed to all the patients. So it can be, in order for us to have enough questions there to assess you or your child successfully, it can be time-consuming and it can be a burden on the individual that is taking the question. Dynamic questionnaires operate a little differently. They're presented in changing sequences, and because the question you get second depends on the way you answered the first question. I think a perfect example of this is when there's such a difference between a child who is a GMFCS 2, a kid who's kind of a runaround kid, with maybe minimal kind of equipment and involvement, versus a child who is running a power chair, right? So it's so frustrating it would be very frustrating to me if I was sitting there having to answer questions about, does your child play soccer, or does your child run around, or, blah, blah, blah. So, but the dynamic questionnaires have the capacity to, as soon as you answer those first couple of questions and the demographics are entered, then they don't ask those questions. It goes straight to another set of questions. And that's the power of the dynamic questionnaires. In addition, of course, it means that there's a technical term. We talk about floor and ceiling effects. Well, you can imagine that if you have a kid who's a GMFCS 5 and you are doing one of these questionnaires, sometimes like all of the questions are not applicable, right? So that's what we would call a floor effect, right? You're just going to score 0 and that's it. Or your kid may be much higher functioning, and so then you're going to end up with a 10, and we don't get any sensitivity. So this is another thing that dynamic questionnaires can do. They can provide us with a depth and breadth of measurement that can allow us to apply the same scoring system to a very broad number of children. So these, the one that we're actually using, and there are others, and I'm not promoting one, but we are using PROMISE both in kids and in adults, which is an NIH-designed measure used nationally, and with with a very broad number of domains. Health-related quality of life, and it includes pain. And in the pain domain, we'll look at in a moment, there are many, many questions behind that pain domain. It's applicable for both adults and kids. So for me, that's important because we're doing a lifespan treatment technique. We have both adults and kids that we're trying to measure, and we're trying to follow our kids into adult life. So pain assessment in this particular instrument has pain behavior as 39 items, pain interference 40 items, pain intensity, pain quality. So these, the names aren't important. It's just that you can see there's just a lot of items. So therefore, with all these items, you would have a better chance, perhaps, of qualifying pain. The domains are outlined below. But this is the reason that I'm so interested in this, and I think it has broad applicability, is that the adult and pediatric scores can be compared directly in longitudinal follow-up. So this is a measure of pain interference, how pain interferes with life. So the raw score in the pediatric area would be 19, let's say. Raw score of 16 in the adult would be the same scaled score of 60. So I can then look at the kid that I evaluated at age 12, evaluating the same kid a decade later at 22, I can then directly compare. Have our interventions, has treatment changed pain interference for this particular individual? So communication of a patient's pain to a treating clinician is, of course, limited by their ability to self-report. And proxy reports are not 100% accurate of the representation of a patient's life. So we particularly, and we know that patients with IDD have motor and sensory and cognitive impairments that lead to communications difficulty. And there really is no comprehensive method to assess the level of pain in all of patients with IDD. And this is something which we all know intuitively, but if you look at the ability to reliably communicate by GMFCS level, obviously as the patient becomes more involved, there is a higher number of patients that are unable to reliably communicate. So why don't we just say, okay, we just have to do as many proxy measures as necessary because it's faster and easier in many situations. But the reason is that there are differences between how a parent and or anybody who's a caregiver will determine health-related quality of life and the patient themselves. And so this is a a study that we did comparing the responses parents gave to the responses that kids gave. And it's pretty clear that, particularly in these three domains, physical functioning, general health, and mental health, all of which are key domains, that there was a high degree of disagreement. And it went both ways. In some cases, the patient, the involved individual would rate themselves much higher than their parent. And sometimes it would be the other way around. But in general, it was more that the kid would rate themselves higher than the parent did. So although evaluated more frequently, CP patients also received lower scores in postoperative pain measured by proxy. So even though this is a patients with adolescent idiopathic scoliosis, these are CP patients, and so their highest recorded pain score is lower than these otherwise typically developing kids with spine surgery. And yet, and all of us involved in this field, we don't believe it. We don't believe that that's really the case, but somehow or other, we're just not getting to the problem. So this is the problem. So we have this reporting data. We have the people that can report for themselves and the patients that are reporting by proxy. Up to 60% of all of our patients with CP have some difficulty with communication. And so we're really interested in introducing tools for self-report so that both kids and adults can answer these questions for themselves. So our goal is to find a way for patient-reported incomes to include more patients in self and fewer in the proxy area. So this is our platform of pain research. We've designed a classification matrix to help stratify individuals with intellectual disabilities to their abilities to self-report. And we also are attempting to validate and adapt PROMIS to these patients with cerebral palsy so that we can give a voice to those who previously have not been heard. So we're looking to decrease the difficulty of the question and then to use a patient's own communication tools or to introduce them, tablets, joysticks, text-to-speech, speech-to-text, to create ways to allow patients to connect and to actually to get into the interface with these instruments and answer the questions themselves. So this is it looks complicated, it honestly isn't very, and this algorithm for determining what a person can use to self-report, we've developed this and it's used in our office, and it's a very dependable way of coming up with a way to help patients self-report. So we want to expand the number of self-reporting patients, reclaim those who were previously excluded, and to give patients a voice and to empower them to be included in clinical trials, included in clinical decision-making, and included in physician-patient communication. So it is important, as you've heard Veronica and I both say, that we measure health-related quality of life, not just pain symptoms. And we need to look for validated, widely used instruments that measure a number of domains. Again, the effect of the pain and its an impact on life and not just the symptoms. And in my own prejudice, we need this powerful, dynamic, broadly applicable instruments that can measure health-related quality of life across the lifespan, because it's my goal before I quit this business to actually have some data on what's going to happen to your kids when they're 25 and 35, and right now we don't know much about that. So we want to use new technologies to help patients with disabilities to communicate and to self-report.